Welcome back to the Living Diabetes podcast. I am your host, and today we are addressing something that is critically underrecognized in diabetes care. It is the difference between diabetes distress and clinical depression. These two conditions look similar on the surface, but they are fundamentally different, and getting the distinction right matters because the treatment approach is different for each. Let me start with a number that might surprise you. Research consistently shows that up to 40% of people with diabetes experience significant diabetes distress at some point, and about 20 to 25% of people with diabetes meet criteria for clinical depression at some point in their lives. These are not small numbers, but here is the problem. In routine clinical practice, they often get lumped together, and that means many people end up with the wrong diagnosis and the wrong treatment. So, what is diabetes distress? Diabetes distress is the emotional burden that comes specifically from living with and managing diabetes. It is the frustration of checking your blood sugar and seeing a number you did not expect. It is the exhaustion of making hundreds of daily decisions about food, medication, and activity. It is the worry about long-term complications. It is the guilt when you miss a dose or eat something you feel you should not have. It is the resentment that this disease never takes a day off. Diabetes distress is a completely rational response to a genuinely difficult situation. It is not a mental illness, it is a normal human reaction to an abnormal daily burden. And this distinction is important because it changes how we should respond to it. Clinical depression, on the other hand, is a mood disorder that affects how you feel about everything in your life, not just diabetes. It is characterized by persistent sadness or loss of interest that lasts at least 2 weeks. People with clinical depression often experience changes in sleep, appetite, energy, concentration, and self-worth that affect all areas of their life. They may lose interest in activities they used to enjoy, withdraw from relationships, and in severe cases, have thoughts of self-harm. The key difference is specificity. If someone says they feel overwhelmed and frustrated specifically about their diabetes management, but they still enjoy time with friends, still find pleasure in hobbies, and still feel generally okay about other areas of their life, that is most likely diabetes distress. If someone feels persistently sad, hopeless, and disengaged across all areas of their life, and these feelings do not lift even when diabetes is going well, that is more likely clinical depression. Why does this matter for treatment? Because the interventions are different. For diabetes distress, the most effective interventions are diabetes specific. Simplifying the treatment regimen, setting more realistic goals, improving diabetes education, connecting with peer support groups, and working with a diabetes educator or psychologist who understands the disease. Antidepressant medication is generally not helpful for diabetes distress because it is not a chemical imbalance. It is a response to real-world circumstances. For clinical depression, evidence-based treatments include cognitive behavioral therapy, antidepressant medication, or a combination of both. These treatments target the underlying mood disorder and can be very effective. Importantly, untreated depression in diabetes is associated with worse blood sugar control, higher rates of complications, and increased mortality. So, recognizing and treating it properly is genuinely life-saving. There is also overlap. Some people have both diabetes distress and clinical depression at the same time. The stress of managing diabetes can trigger or worsen a depressive episode, and depression can make diabetes management feel even more overwhelming. When both are present, both need to be addressed. How can you tell which one you might be experiencing? There are validated screening tools. The Diabetes Distress Scale is a 17-item questionnaire that specifically measures the emotional burden of diabetes across 4 domains: emotional burden, physician-related distress, regimen-related distress, and interpersonal distress. The PHQ-9 is a standard screening tool for clinical depression. Your healthcare provider can administer both of these in a routine visit. If only one is used, important information may be missed. Here is what I want you to take away from this episode. First, if you are struggling emotionally with your diabetes, you are not alone, and what you are experiencing has a name and validated approaches to help. Second, the distinction between distress and depression matters. Ask your doctor to screen you for both, not just one. Third, do not accept the idea that feeling terrible about diabetes is just part of having the disease. It is common, yes. but there are effective strategies to reduce the burden. Follow us on social media for daily updates and more content. Until next time, take care of yourselves.